Welcome back. This is video number 14, Guidewires number 2. This is a case of a nearly totally occluded mid-LED. It is a long lesion ending with a bifurcation with a diagonal branch. The lesion is so tight, leading to late antegrade distal filling. To pass this lesion, what wire is needed and why? And these are the items to be discussed. In this case, what criteria in the guide wire is needed to pass the lesion? Crossing this long subtotal lesion needs high hydrophilicity, high tip load, torqueability, and tip design. Crossability is the ability of the guide wire to advance smoothly through stenosis or occlusion with little or no resistance or force, and without trauma. The track is already determined by the tapering beginning of the lesion. Ability of the guide wire to cross the lesion depends on hydrophilicity by reducing friction so the force is directed to the tip only. High tip load since part of the force is lost in the friction, yet very high tip load is liable to trauma. Torqueability, the ability of the wire for rotation. The spiral motion reduces the static friction sticking between the wire and the plate and prevents buckling or prolapsing. This is discussed later in details. Tip design, tapered tip or cold design, yet it may affect torqueability, and this will be discussed later. As said before, in this non-frontline case, the first step is to choose these criteria from the available wires and not using a frontline wire with a low tip load and low hydrophilicity. And these are the guide wires in the Egyptian market according to the tip load. Pilot 50 guide wire, according to Abbott, it is a 1.3 gram tip load, while in the literature it is 1.5. And this is the guide wire classification regarding hydrophilicity. Wires with intermediate tip load and extra hydrophilicity includes Pilot and PT2 families. So the Pilot 50 was used as a starting guide wire. In experienced hands, a wire with high hydrophilicity and low tip load with more safety may pass till the end of the lesion only. Yet, most probably at the distal end, a high tip load will be needed to pass to the distal LED. In this situation, a tapered tip as filter, especially filter XTA or cyan black wire will be the best choice. Pilot 50 guide wire passed the lesion with relatively ease, yet the tip angle was lost in the lesion with failure to redirect and pass into the distal LED. It passed and parked in the mid of the diagonal branch. There was no space in the lesion to pass another guide wire with a more acute angle. In order to create space for another wire passage and relieve any lateral pressure along the guide wire, allowing free control, there was a trial of balloon dilatation of the lesion, not reaching the bifurcation point. Yet only the very proximal segment was reached and dilated due to failure of passing more distally due to inadequate support. So the issue here is lost tip angle leading to inability to redirect the wire away from the diagonal branch, although a very distal acute angle was shaped. Also, inadequate support to balloon passage. This is a possible issue. So what is next? What is the next option? Pilot 50 guide wire pulled back and redirected after a more acute angle reshaping, or PT2 guide wire with shaped tip preserved, or guide wires with better torqueability and microcatheter with 1-to-1 torque guide wire. A more acute angle reshaping of the Pilot 50 most probably will not pass the lesion. And since the issue here is not rotation or torqueability, it is the matter of shape tip preservation, PT2 guide wire was the choice. PT2MS is of nitinol, which retains tip shape and considered a memory alloy, and it is of moderate support, not as PT2LS, which is with low support. PT2MS guide wire with some rotation past the lesion and parked in the distal LED and supported balloon and stent delivery. And the procedure was completed. So in this case, to pass the lesion, a guide wire with high hydrophilicity, high tip load, and torqueability is needed. To preserve the angle tip, guide wire with some flexibility and better shape retention and better memory. If field rotation, consider guide wire with better torqueability or adding a micro catheter. Guide wires with relatively better torqueability will be at the expense of hydrophilicity or with a very high tip load. So adding a microcatheter is the best option with 1-to-1 torque guide wire. What is meant by shaped tip preservation? First of all, shapeability. It is the ability to modify the guide wire distal tip precisely to access difficult anatomies as inside branch wiring. Low shapeable guide wires are difficult to shape precisely because of elastic nature. More efforts may be needed if hard stainless steel material. Shape retention is the ability of the guide wire to maintain this desired curve or angle. While shape memory is the ability to retain an intended shape after being exposed to deformation and stress as heat or pressure, after this stress is removed. Low shape memory means once it is shaped, it stays bent, doesn't spring back to the original shape after stress removal. Soft elastic guide wires as nitinol has low shapeability, low shape retention, and high shape memory. This long, nearly total occluded lesion with very late distal LED filling and inability to pass two wires in the lesion remodifies the tip to be straight again. The response of the guide wire differs according to the core material of the guide wire and other coil characteristics. With PT2MS, the angled tip is preserved or recovered after passing the long total occluded lesion due to nitinol. It is a high flexibility due to shaping ribbon tip, nitinol, and absent coil, although there is a high tip load. So easily passed in the septal artery, then redirected into the LED proper. While with pilot 50, the angled tip is reshaped and lost after passing the lesion due to stainless steel. Besides core material, other factors may affect shapeability and shape retention. Presence of coils hold shape better, while hydrophilicity, due to its slippery tendency, tends to lose shape quickly. Both PT2 and pilot guide wires are extra hydrophilic, yet the PT2 is not coiled. As seen in this video, shape memory alloys as nitinol, nickel, and titanium possesses the ability to return to their original shape after being severely deformed. Nitinol guide wires in clinical practice in the Egyptian market includes the BMW family, PT2 family, run-through family, the tip only, not the shaft. In this case, BMW family is excluded. It is only for frontline cases. The run-through guide wire family hypercoat may be considered yet with a low tip load. Intermediate is considered yet with a very high tip load and lost extra hydrophilicity. Regarding PT2 guide wire, PT2LS has tip load 2.5 gram with light support, while MS has tip load 2.9 gram and moderate support. The coating is hydrophilic coating on top of polymer jacket cover. The tip core doesn't reach to the end. Instead, it is shaping ribbon. As seen in the figure, the cover is polymer jacket with no coils, with hydrophilic coating over this jacket. Notice the more extended, non-smooth tapering of the core till the end in the PT2LS guide wire. This will decrease the rail support. PT2 guide wire, if compared with other wires with the same moderate tip load, it is considered flexible due to the presence of nitinol, shaping ribbon, absent coils. Also, the polymer jacket and hydrophilic coating increases this flexibility. Tip shapeability and retainment is low due to nitinol, polymer jacket and hydrophilic coating, absent coils with shaping ribbon. Yet the memory is increased due to the presence of nitinol, as said before. The tactile feedback will also be decreased, mainly due to polymer jacket, also due to the shaping ribbon and no coils. Nitinol as a soft elastic material will also decrease the tactile feedback. Penetration and torqueability will also be decreased due to the polymer jacket and the tip configuration, and also due to nitinol. This issue will be discussed later in a separate video. The performance of the guide wire is mainly maintained by the moderate tip load. If it is low with absent coils and shaping ribbon, the performance will be extremely low. So, in addition to the shaping ribbon and absent coils, both lost or decreased tactile feedback and torqueability will lead to easily entrapped and fractured PT2 guide wire. Shaping ribbon with absent coils acts as an unprotected joint. It will hinder or delay or impair any tactile feedback from the tip, any motor power from the fingers, pushing or rotation, although it increases flexibility and decreases tip shape retainment, which may be useful in certain situations. Also, it will decrease guide wire durability, especially if trapped in closed spaces or cases. So, in summary, PT2 guide wire is a guide wire with good flexibility, low tip shape retainment, and good memory, which is useful in certain situations. Yet the guide wire is of less torqueability and lost tactile feedback and easily entrapped and distorted, so should be used cautiously. In this case of C2O, after passage of the PT2MS guide wire till the distal cap, it was replaced with a Gaia guide wire through a microcatheter and parked in the ramus artery, passing in a distal small branch with acute angulation of the tip. After completion of the procedure, guide wires were pulled back, yet part of the PT2 guide wire was detached in the side branch. The possible reason: the wire was partially deformed in the C2O lesion, followed by complete fracture after acute traction due to pulling on the angled tip of the guide wire while in the branch. So, guide wires with shaping ribbon tips, as some of the BMW family and PT2, should be used cautiously when parked distally or in a side branch in bifurcation PCI. While in pilot guide wire, it is stainless steel, not nitinol, core to tip, not shaping ribbon, hydrophilic coating over the polymer jacket in the presence of coil in the distal part of the tip. Pilot 50 is 1.3 gram tip load, Pilot 150 is 2.5 gram, Pilot 200 is 3.9 gram. Pilot guide wire has a radio opaque gold marker at a 15 mm distance from the distant 30 mm radio opaque segment. It includes a non-radio opaque coil segment, helps in measurements during PCI and for keeping wire performance and durability. No dilatation is advised over this segment. Pilot guide wire is a very smooth wire with relative balance between support and flexibility, which is discussed later in the video. Preserved performance, not easily distorted. Its shape retainment property may not be useful in some situations. Pilot guide wire is more radio opaque with platinum than P2 guide wires with tungsten, if compared in the same site and parameters. So the main disadvantages in the P2 guide wire is not present in the pilot guide wire. Regarding core tapering, the tapering may be abrupt within a short distance, stepwise tapering, or smooth tapering within a long distance. Guide wires with smooth tapering. The tapering is not abrupt or stepwise with smooth decrease in the stiffness, less risk of wire fracture and prolapse, torque control and tactile feedback are not lost in transition zone, yet a long distance with less thickness leading to less support. While in guide wires with abrupt tapering, there is abrupt decrease in stiffness, more likely to prolapse and fracture. Torque control and tactile feedback are decreased in the transition zone. Stepwise tapering, there is local flexibility zones with more tendency for prolapse, especially if tapering is abrupt, less smooth. In P2MS, the tapering is abrupt, while it is stepwise in P2LS. Smooth tapering in pilot guide wire. So, pilot guide wire has some balance between the support and flexibility due to this very smooth tapering tip. P2MS guide wire is a highly supportive guide wire due to abrupt tapering at expense of flexibility. This is relatively compensated by nitinol shaping ribbon tip with absent coils. PT2LS guide wire is very flexible with weak points and liability to prolapse due to stepwise tapering. Yet, this is partially compensated with an intermediate tip load. What is meant by trackability? It is the ability of the wire body to follow the tip down a vessel, especially through curves of tortuous vessels, and follow the vascular anatomy. It is affected by tip design, core material wire. So, a hydrophilic nitinol with low tip load tapering tip is the best for trackability. Yet, these parameters may cause prolapse if against resistance. As in this case of BMW guide wire, which followed the coronary anatomy without prolapse, body not following the tip, and parked easily in the distal LED. If the body doesn't follow the tip due to resistance, distal lesion or side branch anchor, prolapse will occur. Prolapse incidence may occur even with less resistance if there is weak points or segments, as in stepwise tapering or abrupt tapering or ribbon-shaped tip. Sometimes it is useful to make a wire loop, as in this case, to pass in a true lumen in the stent, not substruts. This maneuver should only be done with guide wires that has liability to prolapse, as in BMW guide wire in this case. In BMW guide wire, in addition to the abrupt tapering, there is shaping ribbon tip configuration, except in the universal type, as said before, which is a weak point for prolapse. In summary, basic detailed information, gained experienced skills should be known regarding the PT2 and pilot guide wires family. The comprehensive knowledge of the difference between them is essential. They are the most common used guide wires for non-frontline cases, which represent 20 to 30% of cases. And this is the end of the video. Thank you for your attention and waiting for your feedback.